Welcome to another episode of the Align and Elevated podcast. I'm your host, Dr. Allison Feldt, owner of Body Motion Physical Therapy and owner of AF Wellness Community. And I am here with Dr. Melissa Lange again. So we had such a great outpouring of support and questions, and people just love that episode.
I'm so happy.
So I think it was probably like our most downloaded episode on Apple.
Oh my God.
We're pretty stoked about that.
Sweet.
So thank you for doing it, because I feel like
this
is everyone wants to know this information,
Yes.
and it's hard to find like a kind of a valid source of information.
Yes.
So, I have a lot of follow-up questions,
Great.
and thank you for being here. And if there's things that you're like, I couldn't sleep at night because I wanted to share this and I didn't share this,
Totally.
tell us.
I got you.
Okay.
Yes.
Perfect. Cool. Okay, so we talked a lot about getting labs starting in perimenopause and menopause.
Yeah.
And kind of women in their 30s and 40s to get a baseline understanding of their health. But what does that actually look like? And let me give you context.
Of course, yeah.
Because after this episode, I had a friend reach out. She's going to come see you.
Cool.
But she wanted her doctor to order labs. She's like, but what do I ask my doctor to order? And then I'm going to go see Dr. Melissa to like try and, put it all together.
Of course.
And I was like, I don't actually know.
Yes.
And so what would you say is kind of the gold standard that you want everyone in their 30s and 40s to get?
So this is such a good question, and it doesn't necessarily pertain to only hormone health. Like, I kind of have a general panel that I find I order the most frequently for anybody who's presenting to me in a female body, kind of in 30 years and beyond. I'm ordering the same labs. And so like baseline things that I want to see for people are thyroid function is a really big one. I catch a lot of thyroid disease in my practice, and if we have people coming in with vague symptoms like fatigue being one of them, or sleep disruption, or like new onset hair loss is a really big one, and that's an interesting one too within the context of like hormones, because yes, hormones, but usually thyroid hormone for that one. And so I want to see what thyroid's doing. I like to take a peek at like general nutritional status too, and kind of like some low-hanging fruit on the tree in terms of things that could explain some of the symptoms that might be happening in a person's body. And so again, kind of leaning back on the big ones like chronic fatigue that's unexplained, difficulty concentrating, having a tough time with illnesses, having a tough time with hair loss or skin changes, or things that just seem different compared to previous baseline for patients. Iron status is such a big one. I like to take a look at vitamin D, as we live in the Pacific Northwest. Most of us are deficient, or at least insufficient. I like to take a look at vitamin B12 and folate too, because usually if there's abnormalities in either one of those, there's going to be an across-the-board B vitamin deficiency or insufficiency. And so I kind of like to make sure we have all of these pieces in play that are really easy to fine-tune and fix right away before we get too deep into the weeds with other things. I like to look at cardiovascular status, because this is really important if and when we do choose to bring on hormone replacement therapy for a patient. That's one of the big things we have to be paying attention to on a regular basis in terms of responsible medication management. You may have heard before that when you do introduce things like testosterone and estrogen, we have increased risk of cardiovascular events, including blood clots, for example. And so I want to take a peek at what does this person's cholesterol look like, and if their cholesterol comes back high, which I'm going to put an asterisk next to. I think we talked about this a little bit last time, but I'll loop back around in just a second. If their cholesterol comes back pretty high, I want more information before I'm going to onboard estrogen especially. I also want more information before I'm going to onboard testosterone. Finally, I like to look at things like morning cortisol, which is also a hormone which kind of plays within the bigger picture of everything. I like to look at a complete blood count, because when we do bring on testosterone in particular, we can see an increase in red blood cell markers, which isn't always a good thing. And so there's kind of all of these pieces we just need to know to make sure that even bringing on hormone replacement therapy is reasonable for the patient and going to be a safe option in their body. We got to get kind of a baseline there. There's a few other things that I kind of plug in here and there depending on what the patient's picture of symptoms looks like, but really those are the kind of the big handful of things that I need to look at right away just to kind of see what we're working with, and if there's anything else that might be causing symptoms that's not related to reproductive hormones.
Yeah. That's such a good, thank you.
Yeah,
Very
you
thorough
got
response.
it.
The reason, so the same person, so she is also in my wellness community, and she is for months now, since April, checking all the boxes, like getting her 10,000 steps a day, drinking her water, getting her protein. Her macros are in a place where it should be a caloric deficit, and she's doing it and hitting it and weightlifting, and nothing is shifting her fat. Like she wants to lose fat, and I'm like, there's something off here, because. First off, like I don't like to ruin people's metabolism by putting them on 1,200 calories a day. Like that's never a feel good place.
Absolutely.
Like to get nutritional,
100%.
You know, for the body, and when
It's
you're
not worth
lifting weights and like everything, like you need caloric intake and fuel to go through your day. And so, so that's why I'm like, we have to get your blood work. Like you have to figure this out. Like there's something else. And one of the concerns, and I'm saying this in her, I think she'll be happy I'm asking you these questions. But I also have like a lot of other people in my wellness community, and they like very similar sentiments. And I think that like they get their normal blood work done, and then it's not optimal. And you're like something's still off.
Totally.
And sorry to like tangent this a little bit, but one of their biggest fears, like some people go on the GLP ones, but one of like my friend who I'm specifically talking about, like she's like, I really want to try and do this naturally. Like I don't want to do the GLP ones. Like I'm worried about the side effects. I want to prioritize my muscle. I want to prioritize doing this without that, and I feel completely hopeless. Is kind of like the boat that she's in.
100%.
And so it's heart-wrenching for me, and that's why like I'm like, just see Dr. Melissa Lang and like
sure.
have her like break down everything.
Yes, absolutely.
But like, I guess my question to that, and I do want to dive into HRT, that's what I wanted this to be about, but is there, I'm tangenting, and I think this is relevant to a lot of people that have reached out, that's why I'm tangenting.
Of course.
Is, where is that difference? Like, do you, like, I would rather have a client, I have to tell this story, like, I had another client in the wellness community, and she was put on a GLP-1.
Sure.
And she kind of forgot that 12 years ago she was diagnosed with a thyroid condition.
Shoot, yeah.
And you're like, and she never felt good ever, and like she was like, and she never like intuitively wanted to be on the GLP-1, but of course wanted to lose weight like we all do. And so then she like had this epiphany when she was here, and it was like, oh my gosh, I have a thyroid problem, and oh my gosh, her thyroid was so bad. And you're like, you almost think like maybe it's a little dangerous if you're not fixing the problem. I don't know, because I don't deal with that and labs and any of that stuff, but it just makes me worried. So I guess my question, I don't have a direct question because
of course,
but these stories are really common. And so how do you navigate, how should people navigate this? Like they want to lose weight, they want to be on the GLP-1. Not really though. Like honestly,
no, for sure.
I think there's so many side effects that people are like, I want to do this naturally, and we're seeing more and more of those side effects come out.
Of course.
So how do you navigate like getting, like is it just as simple as like, let's make sure your thyroid is optimal, let's make sure all this, the hormones are optimal, and then if we have to, we dive into that?
This is a really good question because it's so relevant right now, and GLP-1s, as we all know, are such a hot topic, and they have been for the better part of the last few years. You know, I want to root my response to this, again, like last time, in that I support women feeling good in their bodies, and also part of that on my end, in terms of like my responsibility as a physician, is to make sure people are staying safe in their bodies. You know, I won't say that I'm against GLP-1s because I'm not. I do have a few patients who are on them, but that's a few out of many. And it's patients who I really like handpick. They ask me the question like, hey, what do you think about this? We've done the whole workup. We're doing all the things. They've got all of the baseline in terms of diet and lifestyle in place. There's a very few in terms of like people who I'd put this on. A couple of things about GLP-1s that I think everybody should be educated about. There are scary side effects. Not everybody gets them, but some of them are pretty significant. And I think it's really important when patients are considering using this as a weight loss strategy to be fully informed about what that might look like. It can cause significant gastrointestinal issues. You know, there's starting to be case studies in the literature indicating that it can cause gastroparesis, which is like a complete slowdown of the gastrointestinal tract, which is a big problem for a lot of reasons.
So I keep going on
Yes.
this, don't lose your train of thought,
Yes.
but we are seeing patients coming in for pelvic
Yes.
floor because they have gastroparesis
Correct.
and they want to try to manage it naturally.
Exactly.
So we're doing EMTT, we're
Yes.
doing shockwave, we're doing our visceral manipulation
Yeah.
to try and get them back their
Exactly.
motility, and it's
Exactly.
working in a very slow fashion.
It's going to be slow if they're still on it too,
Yeah.
because that's the mechanism of action. So to be clear, GLPs, we make this. Like, this is something that our body makes, and it's kind of similar.
No, I didn't know that.
So it's similar to hormone replacement therapy in some ways, because this is a digestive, it's secretion that is intended after you eat a meal to help send signals to the brain of like, hey, we're satiated, or hey, we need to slow down and like really like digest this in terms of the stomach. And so the stomach, things slow down basically to help improve absorption and assimilation, etc. But also it sends this message of like, hey, you're not hungry. And part of that is just like hard stop, halt on the gastrointestinal tract, which is part of the mechanism of action of how it works and how people find this effective weight loss. But is it sustainable? I'm not so sure. Anytime we add something in that the body is supposed to be making normally, like, you know, hormone replacement therapy in its most current stage of like how we refer to it, reproductive hormones post-menopause, that's kind of a separate story, because we shouldn't necessarily have those hormones as high of levels physiologically as what we're introducing for various reasons therapeutically. GLP-1s, we should be making that, and we should be making enough of it. Like, for me as a physician, I really hesitate to prescribe these because we don't have enough data over a period of time of, well, what happens to our ability to naturally produce this if we're on it for a long period of time and then take it away? Like, are we gonna, because there's exactly,
Yeah.
there's a lot of use it or lose it mechanisms in the body, and I don't think we have enough information yet as to whether or not that's one of them. Now, I will say for GLP-1 conversation in particular, I only select this for my super motivated patients who are in danger zone. We're looking at not just, you know, maybe some extra body mass on board. We're also looking at metabolic dysfunction, because let's be clear, the GLP-1 class of medications is originally intended to treat type 2 diabetes because it helps lower blood sugar. You know, one of the nice side effects of it is people for whom metabolic dysfunction was on board and also happen to have some extra body mass on board when they start them, they notice weight loss. And so now it's turned into this weight loss drug because of, you know, it's kind of like an unintended side effect. It's an unintended use that's now being, you know, it's blown up. But anyways, so for my patients who do have true metabolic dysfunction, we're really in the weeds with diabetes, for example, and also, sure, weight loss would help them achieve their overall goals, and they need that short-term crutch while they're layering in the long-term foundations underneath. Super committed, really doing the work around the diet and lifestyle changes that need to happen. Great short-term tool.
Yeah.
They're not intended to be forever medications, nor should they.
Interesting, because I mean, I think that's almost maybe an incorrect thought I had. I thought once you were on it, you had to stay on it.
So for most people, you know, the weight loss, so there's stories in the literature and in clinic where people take it for a period of time, they lose all this weight, and then you pull back on them, like you kind of cold turkey it, and then all the weight comes back. And most of the patients for whom that is true, it's because we didn't address the root cause and there was no implementation of the foundations. So if I have patients who are undermotivated and just want a quick fix, I'm not going to do it because the risks outweigh the benefits, and we're not going to arrive at achievable, sustainable results over time. But anyways, like in terms of kind of parsing out like when, this is so why I like to see labs first, and I like to have a good understanding of like what is going on with this patient, because let's be clear, like bringing on a GLP-1 is not first, second, or even third line for weight loss. Like diet and lifestyle is first line gold standard treatment across the board here. And so as physicians, we got to be picky and be making some good medical judgment around which patients this is a good fit for. Sorry, that was a tangent.
No, myself. I love it because it honestly, like, you can just get this anywhere now, unfortunately.
Yes, which is scary.
Yeah, and you can speak to that in a second. I guess this is taking a complete turn, but I think this is a good turn because it's very relevant. It's very relevant to, like, my coaching community.
Yes,
and
100%.
I just think that we all need this information. I will tell you, like, I don't know if you know my story at all, but, like, I've lost 100 pounds in the last 3 years, essentially since I had Jayla.
Right.
And I didn't want to ever do a GLP-1 for the main fact that I didn't want to touch my muscle. Like, I've always, like, muscle has been my priority ever, always and forever.
Yes.
But the other, like, fact, and I've been really open about it on my podcast, is, like, I cope with emotional eating.
Totally.
And, like, although I've had this successful journey, like, when I come across a stressful event, like, I am triggered to go to food to cope. Yes. And that's, you know, I'm not proud of that. Like, I don't like to say that out loud, but that is the the reason.
Sure.
And so I almost think if I went on a GLP-1, like, I always try to deal with my root cause. Like, feel the emotion, figure out what is causing me to go through cycles of emotional eating, and break it down. And that's honestly been a huge part of my 3-year journey. And I just came across a stressful period, and same thing. If, like, those habits return, and it's like, okay, now I gotta go figure out why I'm doing that, and I need to have a different coping mechanism, because it's truly, like, an addiction, and that's not great.
Yeah.
And I think if you put someone like me on a GLP-1, even if I didn't have the signal that I was hungry, or if I didn't have the signal that I wanted food, like, I would still emotionally eat through it.
Totally.
And maybe not while I was on the GLP-1, but absolutely afterwards.
Totally.
And that's where it's like, again, like, if you're not working on the root cause.
Exactly.
But I can sit here confidently because I don't really care what anyone thinks of. I mean, I care, but there's, like, I'm very open that, like, you know, it's been a journey, right? And that's how I cope with pain and stress and all the things.
Sure.
And we all have our story. And so I think what's really hard, though, is, and it's not even a motivated thing. Like, when you have a patient that comes in, they might be motivated in that hour that they're seeing you, but life is just chaotic and they can't get it together. So it is so... We all just want the quick fix and the magic bullet, and, like, you know,
it's hard, right? Like, it's interesting because the state of things. I want to make sure we come back to the muscle mass issue with GLP-1s, because I think that's another point that people need to be educated about. But you know, the landscape right now in terms of major disease burdens and top causes of mortality in the Western world are lifestyle related, and it's hard when your whole environment is constantly promoting things that are not good for long-term health, like health period, not just like surviving, not all of these things. Like, we are not encouraging as a healthcare system, as a society, like, actual healthy living that is supportive of longevity, that is supportive of years in your body where you actually feel good and have high quality of life. There's a lot of messaging in general that's the complete opposite of that, right? And so it is so hard when everything is so instantaneous. We have information at our fingertips. We see Instagram reels right and left that basically make things seem as though they were an overnight success, when the reality of the matter is that is so heavily veiled behind a highlight reel, right? And if we're looking at, like, sustainable change over time that people can maintain and don't need the crutches of modern medicine and pharmaceuticals to continue to live a life that they deserve, like, the reality is it takes time and hard work. Even though it shouldn't be hard work, this is where we're at. We're in a fertile ground where it's going to be hard work for any given person on any given day, unless you're living, like, remote on a commune and living your best life, right?
But, I mean, and, like, if you are a listener of this podcast, you know the fulfillment and the joy is found within that hard work.
Exactly that.
At the end of the day.
Exactly.
And it doesn't matter how much weight you lost, what size your body is.
Exactly.
the journey is the fulfillment, and I think that's so relevant in the health world.
I think so too. And again, quick fix is not actually a fix, it's a band-aid.
Yeah.
So I think that, you know, when we continue to reorient the conversation around like making sustainable changes for like our generation, our kids' generation, in terms of like healthier bodies over a period of time, there has to be like a cultural shift too happening because of the messaging that's happening that normalizes things that kind of set the stage for us needing to use Band-Aids at any point in time to kind of help keep people out of the weeds with things that are actually pretty dangerous in their bodies, you know?
Yeah.
Yeah.
Okay, dive into muscle mass and dive in. You flinched when I said you can get the GLP-1 anywhere. So tell me why you're flinching.
God. I'm flinching because I don't think there's good medical decision making happening around the kind of like I won't throw brands under the bus. But, you know, you see these commercials come up and it's like, you can get GLP-1s through the mail. All you have to do is hop on and blah, blah, blah. And, like, let's be clear. You know, maybe there's some good programs where they're actually doing some good screening, but probably not, okay? Like, probably not.
If you missed my client that had Hashimoto's, that's a problem.
It's a problem because, again, there's like a very specific population for whom those medications are actually really reasonable to bring on board. And I can tell you right now with the GLP-1 situation, it's all just a money grab. Like, I hate to say it, but it really is. It's very lucrative, but, you know, that's not good medicine, okay? In terms of GLP-1 medications, I was listening to a continuing education module recently about just, you know, learning about GLP-1s and the current data in terms of meta-analyses, which are kind of like the big studies that come out that look at all of the other studies and then combine all of that data to give you like, here's what's actually happening. Meta-analyses indicate that up to 40% of weight loss happening on a GLP-1 is muscle mass.
No.
Which is so bad, you know, for multiple reasons.
40%.
Up to 40% of weight loss is due to muscle mass loss.
So you lose that and then you regain all the weight, you're just regaining fat.
Correct.
Because it takes years to build muscle.
Correct.
And over the age of 40, you're losing muscle.
Yep. And
Holy
so
cow.
when we see some, you know, like there's that term Ozempic face, a lot of that is muscle mass wasting, right? And so big issues with that in terms of sustainable weight loss, like muscle is extremely metabolically active. And so the more muscle mass that we have on our bodies, the more calories we are naturally using on a day-to-day basis just to maintain that tissue as is because it's so metabolically active.
Yeah.
So when it's like we're shooting ourselves in the foot, you know, when we kind of like bring this medication on board, you're risking losing a lot of muscle mass and thereby making that foundation we're trying to work on in terms of diet and lifestyle changes a little bit of an uphill battle because we're losing our most metabolically active tissue, which is bad. Also, you know, when I think about especially women in this perimenopause and beyond age, when we're losing muscle mass, oh my gosh, think about the other consequences that can kind of happen down the line there.
I honestly used to lose sleep about this.
Well, yeah, because, you know, we talked about last time, as you're going through perimenopause, we just have the roller coaster of estrogen all over the board. Like, it's all over the place. So estrogen is not as much of a concern during that time, aside from it's annoying and it's causing a lot of the annoying symptoms. It's menopause, when you hit that mark of menopause where estrogen is just lower than it's ever been in your life, we see increased risk of osteoporosis being a really big one. And we know that one of the mainstay first-line treatments for osteoporosis and or osteoporosis prevention is strength training, because when we have our muscles applying forces onto the bones, we're telling the bones, hey, you need to reinforce this area and get stronger. Now, without estrogen in the picture, we already are at a little bit of an uphill battle with that. And so if you're reducing your muscle mass, you're reducing the amount of load that can be applied on the bones, and we're increasing thereby our risk of developing osteoporosis, which for me is a big no-no, because osteoporosis then down the line has all of these other potential catastrophic repercussions, including hip fractures, which is a big one.
What is the stat? You fracture a hip and you're dead in how many years?
I mean, it's like 5-year survival rate is so low.
Yeah.
And
Yeah,
it's
that
not
sucks.
good. You don't recover.
And by the way,
well from
osteoporosis is bone thinning,
Yes.
and then same with osteopenia is like right before you get to osteoporosis.
Correct.
One thing that actually, this is triggering for me, this conversation is amazing, is that like what we've seen in my practice, and I've spoken to it a little bit on the podcast, is that a really huge rise in postpartum fractures.
Yeah.
Because that initial estrogen is
Yes.
so low, but I also think maybe our baseline of muscle mass going into pregnancy is so low.
Yes.
And so that's been a really scary
Yes.
thing to see. And then when I'm having all these moms get postpartum fractures, or
Right.
they end up here, right,
Yes.
like at some point in their journey, and it's like their physicians never ordered a bone density scan.
I know.
And you're like, what?
I know.
You are postpartum.
I see this
This
all the
isn't
time.
this isn't normal for you to just fracture your foot because you've been walking.
Exactly.
Like, let's talk about this. Or
Exactly.
even if you tripped and you fell on your stairs.
Yep.
Like, this is a problem, and so it's not being addressed. So you think that we take all these women, because this
Yes.
postpartum women to
Yep.
like 35 to 45, 50,
Yep.
like you still kind of like have that give a shit about what you look like.
Exactly.
I mean, I think most women do for
For
a long
sure.
time. And like, so they're the, like, they are the
Yes.
Ozempic grabber. Like,
Yep.
those, all the GLP-1 companies
Yep.
want their money, and we all want to be, look good.
Of course.
And so it's like, they're going to be the women that, like, you are, I mean, that is the scariest part for me. It's just, like, setting everyone up for these hip fractures.
Yes.
We already have way too high of rates of osteoporosis right now
Right.
in our elderly population.
Yes.
And I think this is a total tangent. Like, so many people end up having these hip fractures, I think, because they never got their glutes back.
Yes.
They all had pelvic floor dysfunction because no
100%.
one had glute, and no one had got their hip extension. They didn't get glute activation back since they had their babies. So they were underutilizing their muscles, having these
Exactly.
compensation patterns. So they had really a ton of weakness around the hip
Yes.
girdle and the pelvis,
Yep.
which is a huge problem that we can do a whole nother podcast on, and I should. But anyways, so yes, I feel like this is probably, like, at the end of the day, we're going to get canceled for this. You know that, right?
It's fine.
I don't care. At the end of the day, like, this is going to probably shorten the life expectancy of women.
I think so too. And when we're thinking about, like, because last time we talked a little bit about, like, getting in and having a good understanding while you are in your quote unquote hormonal prime as a female, right? So we're talking about, like, people need to be going for regular care and having a good understanding of what they're working with, or rather, more importantly, what they're not working with, and need to bring in way before we get into the weeds of, like, perimenopause, right before we transition into menopause. And some of that comes down to this, right? Because when I'm thinking about, like, this increased rate of, like, postpartum fractures that you're seeing, I'm thinking about, well, yeah, like, the group of women right now who are having babies were growing up during that time frame when there was Thinspiration, and, like, it was such a thing to be a size 0 or below. And so we have this, like, generation of women who are at a baseline malnourished for a number of reasons. And then you hit pregnancy, which is a roller coaster in and of itself, and not so smooth for every body, especially. And then you get postpartum, which is kind of, in a lot of ways, it's kind of like perimenopause, because
Totally.
of how hormones are just all over the place there for the first up to a year afterwards, and maybe beyond if you're breastfeeding for a long period of time. But when we're showing up to the game with, like, an incomplete nutritional status, or whatever it might be, like, all of this is cumulative. And so if you think about, like, yes, we arrive at that postpartum stage and we already are kind of depleted for a number of reasons, like, a lot of women push through that because that's what we do as women. Push through all of the hell of that, and then arrive at menopause, and they're so depleted because there's this huge accumulation that has, at this point, happened over the lifetime that nobody's ever addressed, right? And so this is why I'm such an advocate for, like, making sure women of all ages are really educated about what's happening in their bodies hormonally, and this starts during our kids' age, right? Like,
Interesting.
before they even hit puberty, kind of the very beginning of puberty, we need girls to be informed about what's coming, what's happening, how do you take good care of your body, because that has been such a taboo topic, especially for the female body, for, gosh, ever. It's getting better, thankfully, but it's not great yet. We're not there. And as such, we set female-bodied individuals up for failure.
Yeah.
because they just don't know how to take care of themselves within the context of a female body.
Yeah.
Period.
Okay, well, okay, we're going to curb that. Like,
Yes.
we are going to go into, I'm having you back on this podcast. I'm literally going to suck everything that you're willing to give us out because I want to know what you're sharing with Natalie. Like, I want to know that. And also, like, I will tell you what I'm sharing with Chloe from, like, a pelvic floor perspective.
Yes.
Because I think that would be a great episode. Like, what are we teaching our daughters?
Yes.
Because, like, for me, I, like, in the same vein that you're talking, like, from an internal perspective, like, what's happening in your body, what do you need to flourish in this female body? It's, like, very similar to, like, you need to know how to pee and poop and, you know, explore your body and, like, know what's happening in your body and also know how to control your pelvic floor.
Exactly.
No one teaches us this stuff.
No.
And so women, like, I've never met a woman that has, like, a totally vibrant, healthy pelvic floor.
Oh, yeah, no.
Like, it's like, it just doesn't exist because we hold stress on our pelvic floor. No one's ever really taught us how to poop or pee.
Yep, totally.
And, like, and so it's just, you know, we're taught to, like, stand up tall and suck our guts in. And, like, usually that means you're stuck in, like, this chronic kegel.
Totally.
And so, I would, like, I have actually always had on my mind, like, I need to do a better job teaching Chloe. And we have, you know, we talk about this stuff and she knows I'm, like, when she's on the, you know, pooping, I'm like, breathe, like, you know.
No, totally.
But, like, that would be a great, we'll segue that, but comment below on if you're watching this on YouTube. Comment below and let us know if you want us to do an episode on that because I feel like that would be epic.
That would be a good one.
Yeah, but I interrupted you, and you're like, that starts at that, like...
Yeah, this is why we have to start so early with just making sure that women are educated about what's happening in their bodies and what their actual needs look like. And also, as physicians, why we need to, like, take women seriously, and we also need to start earlier in terms of routine screenings, making sure what people have in terms of a baseline, making sure that if, like, something as simple as, you know, we live in the PNW, we've already talked about this, vitamin D deficiency. Allison, I can't even tell you how many times I diagnose this on a weekly basis. In women, that is catastrophic, potentially, because vitamin D is the key, basically, in the gut that allows for calcium absorption. Calcium is a key component of bones. We need it, right? And so if we're thinking about bone health, but also just general, like, electrolyte balance and having all of the building blocks that you need, like, we need to catch those things sooner rather than later because, you know, like, when we're thinking about bone health in particular, like, your bones are, all of the DEXAs, for example, so bone scans where we kind of screen for osteopenia and osteoporosis, what's called the, oh gosh, I'm going to screw this up. There's two scores. There's a T-score and there's a Z-score. I believe the T-score is the one that's based on this, but we might put an asterisk in the comments below.
Okay.
T-score is really looking at, like, bone density compared to peak bone density in a 30-year-old woman. And so when you hit 30, that's, like, the highest your bone density is ever going to be in theory, right? But what we're finding is a lot of women are kind of showing up, like I was just saying, to that game deplete and deficient already because we've just allowed these nutritional deficiencies to go, like, under the radar or just not looking for them, not really keeping in, like, you know, when I think about individualized medicine, I also have to look at, like, geographically, where are we? Because there's things geographically depending on, like, for example, just we don't get full spectrum UV light here at any point of the year. So it's really hard to have normal vitamin D in the Pacific Northwest without supplementation these days. End up, right? But also geographically, like, what are the trends here? What are people eating? Like, we live in an area where veganism, for example, is, like, a really big thing. Great. We need to make sure that things like iron and B12 are replete for people so that their body can move through normal physiological processes. And then all of these micronutrients that might seem like they have nothing to do with hormone health, they sure do. Iron, to make sure that you get oxygen to all of your tissues. Like, it's so important for everything that's on board. B12 is critical in terms of, you know, it's, like, known for being an energy producer, like, it helps boost energy, but also, like, B12 is important in terms of being a cofactor in a number of biochemical processes, including neurotransmitters, hormones, etc. And so all of these things contribute to the picture. And so we need to make sure earlier and earlier in life that we're setting good nutritional foundations so that we have all the building blocks that we need to have healthy hormones and hormonal transitions as we move throughout the lifespan.
Interesting.
I don't remember how we got on this tangent.
No, I don't either, but are you taking Natalie's blood work?
Not yet. So she's going to be due for her 11-year-old screening very soon. So next year she'll be due for her pediatric lipid panel, and I will be adding a couple of things to that panel for her just to kind of like make sure that we're good across the board.
Yeah, fascinating. Some random tidbit on vitamin D. When I was, after I had Jayla, first off, I'm going to just tidbit for a second,
Sure.
and we can totally come back to
we're good.
another episode of HRT, but because this has been epic, like truly learned so much already. But when Kano was born, I just failed as a mom and didn't give him the vitamin D drops. Okay, so it just never felt right. Then, like a month later, I get a recall notice in the mail. Get rid of all your vitamin D. It's all like it had bacteria. It was tainted. And then I was like, shoot, I just followed my gut. Like I'm glad. It wasn't until Jayla was born, and again, supplement vitamin D for your babies. Yeah. And then I met this lactation consultant because Jayla had a tongue tie, and we ended up going down this journey with her. And she was like, oh, you can just take 5,000 IUs of vitamin D a day as in your postpartum, and she gets plenty of vitamin D. You don't have to supplement. And I was like, well, why didn't someone just tell me that? And I was already I've always supplemented vitamin D for as long as I can remember. But it was like, just no one had, or 5,000 IU. I don't know what I said. But like, that's like, you're just like, these are like the little things that, and you're like, a lot of people don't feel right giving their babies random vitamin drops because you're like, I'm breastfeeding, they should be getting all of this, or maybe they're formula feeding and they're getting, I think you get vitamin D in the formula. But like it's just like those little things, and
at the end of the day, like with little ones especially, like you're, if you have the luxury or you want to breastfeed, like you are still the source, right? And all of their nutrition is coming from you. And so like we don't put enough emphasis on like mom needs to be like treated like a goddess the whole time during postpartum. Number one, to replete herself. Most importantly, to replete herself. But also, that's how a baby gets nutrition too. And again, these are just things because, breastfeeding was taboo for a period of time, like how dare. But we just don't do enough education, again, around women's health and why it's important. And I think it's so critical for women to like take back that information and like embody it and own it, right?
Yeah, truly. Okay, I think that's a good wrap here.
Cool.
And we will definitely come back on and do like a dive into different types of HRT. But I feel like this segue into like, what do you need to have a perfect optimal picture has really, really been amazing. And
absolutely.
And I think that's one of the things I value most about you. And I probably have said this before, but it's like, I love that you're not just looking for normal and like standard. You're looking to optimize the human body, which is like when we're talking longevity and we're like, if you're shooting for longevity, then you're achieving optimal health. And it's like, that's where it's just like, that's where the optimal, like, you want your numbers to be optimal. So
you do, absolutely. And like, you have to look at people as a whole person too, right? Like, I put a lot of emphasis on labs during our conversations because for me, I like, when I'm treating something that's treatable, like labs are so important for me in terms of my decision making of like, ooh, what is critical and absolutely needs to happen. And also, like, that is such one part of a very big puzzle. And so, labs or no labs, we're still training the individual. We still have to bring everything that's on board for them in when we're making some good clinical teamwork decision making together between myself and the patient and anybody else who's on their care team. But I think it's just so important to have a good understanding of what your baseline is since we started our conversation with like labs. Like it gives you such good information and it helps oftentimes to contextualize other things that are happening, including symptoms. So that's kind of the good starting point there.
Well, thank you.
Yes, definitely.
We'll drop your information at the bottom of the podcast. And you can book with Dr. Melissa Lange at Seattle Natural Medicine, North Seattle Natural Medicine. And check her out. This has been amazing. Thank you for giving us all the information that we need to be healthy so we can go live these happy, joyful, fulfilled lives. So thank you.
You're welcome. Thanks for having me.